And bear with me, I need to get it back to the beginning. All right, thank you to the PSU NISHLA board and chapter for sponsoring and organizing this talk along with other great presentations over this year. I am happy to have the opportunity to present some of the research completed through the Speech, Swallowing, and Respiration Lab to the Speech and Hearing Department and to the community. As indicated in the title today, I will focus on our study of the impact of non-invasive ventilation on speech in individuals with neuromuscular impairments, specifically muscular dystrophy. I'm going to just take a moment and make sure I am sharing sound for videos later. And I don't see that option right now, so we'll test that out once I get to a video again. Next, I want to take a moment and acknowledge my primary collaborative research team on this topic. So the team includes Dr. Jenny Hoyt from the University of Arizona. Dr. Hoyt is a specialist, a nationally, internationally known specialist in the area of respiratory support for speech for individuals that require mechanical ventilation, different forms of mechanical ventilation. Dr. Joshua Bendit is a pulmonologist at the University of Washington Medical Center, and he's also internationally and nationally known for his work with non-invasive ventilation. First, I'm going to briefly provide some basic background information about respiratory muscle impairments. There are many different types of neurodegenerative diseases that lead to weakness of the muscles for breathing. This is true for muscular dystrophy and also for neurodegenerative conditions such as ALS. There are also neurological conditions that are not neurodegenerative that can lead to this as well, such as traumatic spinal cord injury. So as is shown on this slide, the diaphragm is our primary muscle for inspiring or taking in air. When this muscle becomes substantially weakened, there is typically a need for mechanical ventilation. Strength of the abdominal muscles of expiration, which is primarily the abdominals, is needed for things like having an effective ability to cough and ability to yell or to speak loudly. Patients with neuromuscular disorders typically undergo pulmonary function testing to measure the volume of air that they can breathe in and out and the strength of the muscles for breathing. The measure of forced vital capacity indicates how much air you can breathe in and blow out fast with your maximum effort. There are also a couple of measures that examine the strength of your breathing muscles. So for example, maximum inspiratory pressure reflects, it's a pressure measure that reflects the strength of your diaphragm and the other smaller muscles for inspiration. And then there's maximum expiratory pressure that reflects the strength of your expiration muscles, such as the abdominal muscles. So these numbers or measures, along with others, are used to determine timing for introducing mechanical ventilation in people who have respiratory muscle weakness. In the muscular dystrophy and ALS populations, non-invasive ventilation is typically offered when the forced vital capacity is less than 50% of what would be predicted for the individual. So now I'm going to just move on to orienting you to what is non-invasive ventilation. So we want to think about invasive versus non-invasive ventilation. So invasive ventilation means that ventilation, or in other words, delivering air to the body, is accomplished invasively. So that would be either through a tracheostomy or through intubation. So I've got pictures of both here. Tracheostomy is typically a surgical procedure through the neck to deliver air into the trachea. And then intubation happens to a lot of people if they're admitted to an ICU, where a tube is placed in through the mouth and then down into the airway. And then that tube can be attached to a mechanical ventilator. And then there are many different forms of non-invasive ventilation. In the past, there have been many different forms. A few of them are shown here. So the abdominal pneumobelt, which contracts to create a negative pressure in the body to naturally draw air in. The rocking beds were used way back in the 40s and the 50s. The person would rock, and then the impact of gravity on the body would move the diaphragm to create a negative pressure inside of the body to naturally draw air in. And by the way, negative pressure is how we breathe naturally, because as our muscles contract, it expands our thoracic cage and it creates a negative pressure that draws air in. Chest shell was similar. Current methods are what we call positive pressure ventilation. So the nose mask and the facial mask methods of non-invasive ventilation are positive pressure, meaning air is being pushed into the body. And here we have some examples of positive pressure non-invasive ventilation that can be delivered either through the mouth, through a nose and face mask, or just through the nose. It could be a nose mask or nasal pillows, for example. So there has been an evolving trend of increased use of non-invasive ventilation to compensate for respiratory muscle weakness in individuals with neuromuscular disease over the past couple of decades. This has occurred for many reasons, but most notably, it's been observed that non-invasive ventilation versus invasive has led to increased survival in populations and reduced incidence of pneumonia, which also, pneumonia can be life-threatening, so that also adds to the survival benefit. On this slide, I'm going to orient you to a couple of basic types of non-invasive ventilation commonly used or currently used in individuals with neuromuscular disorders. So we see here on this slide, mouthpiece ventilation is contrasted with bilevel positive airway pressure, also known as BPAP or BiPAP. So mouthpiece ventilation, the ventilator is set to deliver a set volume of air per breath. And it is, as the name implies, it is typically offered through a mouthpiece. Conversely, bilevel positive airway pressure is set to deliver a specified air pressure. So BiPAP is pressure triggered, whereas mouthpiece ventilation is volume triggered. So a set volume versus a set pressure of air. BiPAP also alternates between having a higher pressure on inspiration and a lower pressure during the expiratory phase. And it is typically offered through a nasal mask or a face mask. So despite the enormous benefits, our prior studies in people with Duchenne muscular dystrophy have shown that the pressure support forms of non-invasive ventilation often interfere with speech by causing muffled speech, as you might imagine, because of the mask, having abnormal nasal resonance, but also difficulty in coordinating speaking with the ventilator delivered inspirations that are pressure triggered. And when I was at the University of Washington years ago, Dr. Jenny Hoyt and I hooked ourselves up to BiPAP just so that we could experience what is it like to speak with BiPAP. And literally every time I opened my mouth, the ventilator would detect a drop in pressure and it would deliver a blast of air. So as I was trying to speak on expiration, the ventilator was then delivering inspiration. So it made speech more difficult to coordinate. But further, the need to wear a facial or nasal mask can be uncomfortable, and it can interfere with nonverbal forms of communication, such as facial expression, and for people that require augmentative communication to communicate, it can interfere with access to eye gaze to control a computer, for example. So for these reasons, many of the patients that require this sometimes self-limit to using their breathing device when they're sleeping or when they're napping, and that potentially can exacerbate their daytime breathlessness, hypoventilation, and reduce breath support for speech and swallowing. All right, so on the next few slides, I'm going to be reviewing some of our prior studies looking at non-invasive ventilation and the benefit of mouthpiece ventilation for speech and swallowing, primarily in muscular dystrophy. So first I want to point out that non-invasive ventilation in young men with Duchenne muscular dystrophy has nearly doubled their survival. Back maybe 10, 20 years ago, before non-invasive ventilation had developed to the point where it is today, most young men diagnosed with Duchenne muscular dystrophy would pass away before the age of 20. Now, thanks in large part to non-invasive ventilation, Duchenne muscular dystrophy is no longer considered to be a purely pediatric condition. And as a case in point, our oldest participant was 43 years old. So note that some of the benefits of non-invasive ventilation are lower incidence of pneumonia and improved survival. So as I indicated, this has been true for Duchenne muscular dystrophy. It's also been true for the ALS population, where there has been a median of at least a 7-month improvement to survival. Other studies, it's actually been higher. And that benefit to survival far surpasses what any of the ALS medications have reported. So the benefits are substantial. Other benefits include things like improved quality of life and having a reduction in some of the risks associated with invasive forms of mechanical ventilation through tracheostomy. And then my research is seeking to point out the possible preservation of physiologic functions for speech, swallowing, and cough. Okay, so in 2019, we published this qualitative study where we interviewed 12 mouthpiece ventilation users. Most of them had muscular dystrophy. There were a couple of participants who had post-polio, who were diagnosed with post-polio syndrome and spinal cord injury as well. With mouthpiece ventilation, most of the participants felt it was easier to swallow. So I have some of the quotes from some of the participants on this slide. One participant stated, "Now that I use non-invasive ventilation with every breath, it is easier. I just alternate breaths with swallowing. I usually take a breath before I swallow." Another stated, "Prior to NIV use, I had to figure out a way to eat without running out of air." Another one, "It's easier to chew after I've had a puff of air. I can swallow a lot easier with the use of the ventilator." And another stated, "It's not as exhausting." All right, so let me move on to another. So most of them indicated that mouthpiece ventilation improved their eating and drinking experience. Most indicated that mouthpiece ventilation reduced swallowing related shortness of breath. And they also reported that mouthpiece ventilation improved their ability to cough effectively. One benefit of the mouthpiece ventilator is that the individuals can do what's called breath stacking, meaning they can take a breath of air, hold it, take another breath of air, and fill their lungs more fully in order to have a stronger cough. All right, here's another qualitative study that we published regarding the impact of mouthpiece ventilation on speech. So we interviewed men with Duchenne muscular dystrophy who used mouthpiece ventilation. In this study, the participants reported that speech was better with mouthpiece ventilation than without it because they could say more on a breath, they could increase their loudness and be more understandable with improved overall endurance for speech. However, a caveat was that they also reported interference with the flow of speech, mostly due to the increased breath pause time needed for inspiration. All right, and this is our most recent study published just this year that examined speech production in participants with muscular dystrophy with and without mouthpiece ventilation. So in this study, we had 8 male participants aged 23 to 44 years. 7 had Duchenne muscular dystrophy and 1 had Becker muscular dystrophy, which is Becker is very similar to Duchenne, but it progresses slightly more slowly. All of the participants used mouthpiece ventilation during the day and bilevel positive airway pressure at night. These participants had a lot of experience with using mouthpiece ventilation on average, one of them for as long as 17 years. That was our oldest participant, age 44. And the minimum was 3 years of use of mouthpiece ventilation. So the purpose here of this study was to compare speech measures. So we compared breath group length and speech sound pressure level, relative speech sound pressure level with and without mouthpiece ventilation in participants with muscular dystrophy. We had 3 conditions that we were observing participants with. The first was their natural use of mouthpiece ventilation. We offered no instructions with this condition. And then we observed their speech when they were cued to avoid using mouthpiece ventilation, only as tolerated, of course, and we were monitoring oxygen saturations for safety. We did have 2 of the 8 participants that were not able to do that. They were not able to complete all tasks without using their ventilator. With those 2, that we just instructed them to see how far they could get with the tasks without ventilator air, and then of course they would take a breath as needed. And then the third condition is participants were cued to inspire using mouthpiece ventilation for every speaking breath group. The speaking tasks that were observed were sustained phonation, counting as far as possible on one breath, and then reading a paragraph. In this case, it was the bamboo passage. All right, next I'm going to show a video. And the video that I will show you, the participant is going to attempt to read the bamboo passage without ventilator air. However, this was one of our participants that literally was not able to get far without ventilator air because he did not have sufficient subglottic pressure to speak without the ventilator air. And then subsequently, after he takes a breath from the ventilator, you can hear the difference in his speech when speaking on ventilator air. And I'm going to just pause here to try to make sure I do have share sound checked. So hopefully this will work. Okay, so. Yeah, so we'll say as much as you can tolerate without the vent, but then when you need the vent, take the vent. call it a word.
Yeah.
Okay.
But we tried.
Say what?
We tried it.
We tried it. That's right. We tried it. All right, so what he was doing there is he was blowing out, he would take a breath, blow out his ventilator air, but then when he would try to talk without the ventilator air, he was not, because he didn't have adequate respiratory support, he was just literally not able to vibrate his vocal folds adequately to get any sound out. Yeah. All right, so a little bit more on our data analysis methods. All of our sessions were audio video recorded in a relatively quiet room in participant homes. The audio and video recordings were used to verify the location of the natural inspirations as well as the ventilator inspirations. So for the natural inspirations, we would look for audible breath sounds. Because these individuals had respiratory muscle weakness, it was more subtle to identify this. It wasn't, the movements were not as large as they might be in a healthy individual. So we look for sometimes nasal flaring, chest wall, shoulder, accessory muscle, and tongue movements. And then for the mouthpiece ventilation inspirations, those were more obvious because we could see the placement of the mouthpiece in the mouth. We could see cheek puffing, chest wall, and shoulder movements. PROT was used to analyze within subject averages of breath group duration, breath pause duration, syllables per breath group, and relative sound pressure level. So here, this was our comparison during the uncued condition, where with paragraph reading, we looked at natural versus ventilator inspirations. And there was quite a bit of variability here. We had at least one participant that used the mouthpiece ventilator for literally every breath taken while reading. And others, it was some natural breaths and some ventilator breaths. And then we had several others, at least 4 other participants, at least one participant that used all natural breaths. And pardon me, we had several that used all ventilator breaths. So variability there. This figure shows breath group duration in seconds for all 3 tasks: sustained phonation, counting, and reading. All of them were significantly longer on average with mouthpiece ventilation than without mouthpiece ventilation. And this pattern held steady for all of our participants. With the reading task, we observed longer breath groups along with more syllables per breath group with use of mouthpiece ventilation. That will be on a subsequent slide. However, 2 of our participants were unable to speak or get adequate voice production without ventilator supplied air. Here is our graph showing our chart showing syllables per breath group. We observed longer breath group durations with mouthpiece ventilation than without. And these were reflected in significantly more syllables per breath group during reading. On the reading task, oops, need to move this forward. Here's the syllables per breath group. On the reading task, we also confirmed the caveat of having a long pause time between utterances, which occurred due to time needed to take a breath of air from the mouthpiece ventilator. So the inspiratory pause duration in seconds during reading was significantly longer on average with mouthpiece ventilation than without. One of our participants was an outlier in that he exhibited very, very long inspiratory pauses because he was breath stacking. So recall I mentioned that breath stacking is this technique of adding one inspiration on top of another to achieve a larger inspiratory volume. And that particular participant was observed to spontaneously stack 2 to 3 breaths prior to speaking. Okay, and then here we are comparing sound pressure level, relative sound pressure level differences. So the participants produced higher relative sound pressure level with mouthpiece ventilation than without, but except for sustained phonation, these differences were not significantly different. All right, I'm going to show you another video at this point. So the first video I'm going to show you will be one of our participants in the without condition. And you will notice that there are shorter breath groups along with evidence of neck or accessory muscle flexion. So if the person is trying to breathe without adequate diaphragm support, you'll see him move his chin up and flexion of the muscles in the neck to try to get more air into the body without the ventilator. Okay.
Do one more breath and then I'll do it.
Okay, yeah, take your time, no hurry.
Bamboo walls are getting to be very popular. They are strong, easy to use, and good looking. They provide a good background and create the mood in Japanese gardens. Bamboo is a grass and is one of the most rapidly growing grasses in the world. Many varieties of bamboo are grown in Asia, although it is also grown in America. Last year we bought a new home and have been working on the flower gardens. In a few more days, we will be done with the bamboo wall in one of our gardens. We have really enjoyed the project.
All right, yeah, so you get the idea that, aside from that first breath from the ventilator, it was very difficult to get a full phrase out. Now I'm going to show you the same participant using the ventilator for every breath. And so you'll be able to see that his pause times are longer. In this case, this is our participant that was an outlier because he was using breath stacking. So that created longer pause times. But you'll also see that he's able to get more syllables out with each utterance.
Okay, great.
Oops, let's try this again.
Do one more breath and then I'll do it.
Take your time, no hurry.
Bamboo walls are getting to be very popular. They are strong, easy to use, and good looking. They provide a good background and create the mood in Japanese gardens.
Oops, sorry. I didn't.
Do one more breath.
Let me make sure I'm on the right video.
Bamboo
Okay. Pardon me. Just want to make sure I have the right thing.
Bamboo walls are getting to be very popular, period. They are strong, easy to use, and good looking. They provide a good background and create the mood in Japanese gardens. Bamboo is a grass and is one of the most rapidly growing grasses in the world. Many varieties of bamboo are grown in Asia, although it is also grown in America.
All right, so you get the idea that there are longer utterances possible with use of mouthpiece ventilation. All right, so in conclusion, mouthpiece ventilation supports longer breath groups along with more speech, more syllables per breath in individuals with muscular dystrophy. We did not see a significant change in loudness, although we also did not test out maximal loudness. A caveat is that there are longer breath pause times associated with mouthpiece ventilation breaths. So for future directions, I just want to let you all know that I am putting together a study right now to examine mouthpiece ventilation in people with ALS. So mouthpiece ventilation is also an option for many people with ALS, primarily those with limb onset, or if they have mild or moderate bulbar involvement. This is something that probably about 20% of people with ALS are prescribed to use currently, but it's not consistently prescribed by neurologists. It hasn't been, with respect to speech and swallowing, it hasn't been studied at all. I'm hypothesizing that for those who have limb onset or more mild bulbar involvement, this will be a way to prolong their ability to speak. But this is a more challenging population because there is more heterogeneity in terms of the patterns of progression. Some people start with involvement of the muscles for speech and swallowing, and others start with the disease in the limbs, for example. But I'm estimating that for those who have adequate lip and velar strength, adequate airflow through the upper airway, and if we begin mouthpiece ventilation early, that those people will be able to benefit from non-invasive ventilation and specifically mouthpiece ventilation. All right, with that, I am happy to take any questions.
Hi, so I thought I'd get us started with just a couple of questions. One question I had as you were talking is, are there any long-term consequences, negative or positive, of when patients are using or clients are using the extra muscles for respiratory support as opposed to just the diaphragm?
Oh, so if they were using neck muscles for breathing as opposed to
Yeah.
being and not having the ventilator support. Yeah, so the thing that happens with that is that they can be prone to fatigue and then also prone to hypoventilation over time. So if they're not able, with the neck accessory muscle breathing, they can get in, many people can get in just enough to get a few words out. But if they're not able to regularly expand their lungs over time due to the lack of movement, the lung tissue and the muscles for the lungs become more stiff. And in the long term, it actually adds to the overall work of breathing. And they can also, over time, have perhaps subclinical mild hypoventilation that kind of builds up over time, and it could lead to ultimately respiratory failure. Great question. Any other questions?
Do you ever see changes in the airway strength? So things like excessive dynamic airway collapse that happen after patients have been on this mechanical ventilation for a while?
No, have not seen that. Yeah, have not seen any kind of airway collapse. In terms of airway collapse, tracheomalacia, that kind of thing can happen more frequently with some of the invasive forms of mechanical ventilation, such as intubation or intubation trauma that can happen. That is more likely to create that scenario.
I was just curious because I actually have excessive dynamic airway collapse and I've been on a BiPAP for it before.
Oh, interesting.
I had a respiratory therapist one time tell me they can speak BiPAP when I was trying to talk on the BiPAP.
Oh, nice.
When you were talking about the communication, I thought that was...
Yeah, I would be interested in hearing more about your experiences with efforts to speak on BiPAP.
I would love to talk to you about that sometime. Let's see. Another potential question is, do the longer pause times with the mouthpiece ventilation negatively influence fluency at all? Or what do you think potentially could be done to mitigate that if it does?
Yeah, great question. We are definitely thinking about that. And I would say, yes, it absolutely disrupts the flow of speech. So in that sense, it doesn't disrupt fluency in the same way that you might see with stuttering, for example, but it disrupts the overall flow of speech enough that without us even pointing it out, patients or users of non-invasive ventilation mention it as a caveat. So to minimize that, the types of things that we are thinking about are, first of all, just placement of the mouthpiece, having it readily available so that the person doesn't need to take time to turn to reach it or to grab it. Sometimes that's an issue. And the other thing that I think we're going to end up advising people when we further develop a training program for use of mouthpiece ventilation with speech is to suggest avoiding breath stacking for purposes of speech. Breath stacking is very helpful for generating a lot more air if you need to yell or if you need to cough. But for speech, it just adds to the pause time. And frankly, as you could hear in the second video, you may have heard this, that if you take in too much air, because the abdominal and respiratory muscles are weak, the individual cannot engage in inspiratory checking to control the flow. So it ends up coming out as a big rush and even leading to some strain at the vocal folds, because the vocal folds for a person with respiratory muscle weakness is the point, is the only control for slowing down that flow of air.
Would using something like because you talked about the nasal pads or the nasal one, could you use that during speech to not disrupt the flow of speech as much by having to go to the mouthpiece? Or is that something that wouldn't work?
I suppose, there is a different form of ventilation out there called AVAPs. That's an alternative to BiPAP. So BiPAP is completely pressure triggered. And when it's pressure triggered, the ventilator is going to deliver a blast of air whenever it senses a pressure drop, unless it's put on a timer. But either way, that could disrupt the flow of speech. AVAPs is also pressure triggered, but it also is delivering a set volume of speech, so you could experiment with that. But either way, the nose mask does interfere or can interfere with resonance. And many of our patients feel like just having something on their face is distracting and interferes for that reason as well. And then the ventilators will be pressure triggered, so they have to coordinate with that. A couple of our participants felt like they were able to speak okay with pressure triggered BiPAP because they had spontaneously somehow figured out a way to tense their soft palate. So when they were speaking, they were volitionally tensing their soft palate to avoid the pressure triggered blast of air.
Could you talk a little bit more about the similarities between Duchenne muscular dystrophy and ALS and how those two projects will be related or different?
Yeah, that's a great question. So the thing that is similar between the two populations is that both of those underlying disorders lead to respiratory muscle weakness to the point of respiratory failure if it goes untreated. And in both of the conditions, the leading cause of mortality would be respiratory failure. The thing that is different, first of all, Duchenne muscular dystrophy is a congenital condition. It begins in early childhood. The first for children, most commonly males. It's extremely rare for in terms of biological sex, a female to be diagnosed with Duchenne muscular dystrophy. I've only seen, in my 20 plus years of experience, I've only seen one female diagnosed with Duchenne. But it's usually young boys that get diagnosed at around age 2 or 3. And for them, the progression begins in the limbs. It always begins in the limbs. And it always starts with difficulty with walking. And then the progression pattern is that it basically moves up the body, eventually affecting the breathing muscles. And then it can eventually lead to some of the muscles for swallowing in the throat. Conversely, with ALS, ALS is typically an adult onset neurodegenerative disorder. So, and it typically, for most people, there are exceptions, but for most people, it begins later in life, say in later 50s, 60s, 70s, on up to 80s for some people. There's also more heterogeneity in terms of the pattern. So for some people, it will start in an arm or hand. For other people, it will start in a foot. Others, it will start in their muscles for speech and swallowing. And wherever it starts, typically it will start in one part of the body and then it spreads from there. So for the people where it starts in the muscles for speech and swallowing, it then starts spreading to other parts of the body. If it starts in the foot, it spreads from there to other parts of the body. The other thing that's different about ALS is that it is much, much, much more rapidly progressive. So those are some of the differences. Great questions.